really quite bad among all healthcare professionals in a pandemic. And so I know we have people from different fields, we have some students, and so hopefully this talk will be applicable to all of you, because really all of us have, I think, at least some burnout. I don't know that there's a single healthcare worker who hasn't had at least some burnout before, but definitely after the pandemic. And so one of the things I wanted to start out by saying is that burnout is not tiredness. So I was just telling Dr. Santos that, I'm kind of on backup trauma and covering ICU, and it's been incredibly busy this week. And I actually had to come in at 1:30 a.m. I got a call because we had 2 cases going, and a patient who needed their spleen out came in. So I'm a little tired, but I'm actually not feeling very burnt out today. It's different. We can be sleepy, we can be tired, but burnout is actually something a little more than that. So it's a combination. There is a component of tiredness, but it's more sort of chronic fatigue. It's more just not wanting to get up every day because you just can't drag yourself out of bed. It's chronic tiredness, not, oh, I was up last night, I'm tired. Oh, I have a little baby who kept me up at night, I'm tired. It's different. It also includes always some element of depersonalization and emotional distancing. You feel distance from your patients, like you don't really care what happens to them. You don't care about your colleagues and coworkers. You start to feel distant and depersonalized, and that's a key component of burnout. And then often just discouraged, like it just doesn't matter what I do. And those are some of the traits that distinguish burnout from normal tiredness or just normal ups and downs, the blues of everyday life. And so those are traits to watch for in yourself. If you're concerned about burnout, that's something to look for, is do you have those traits? And I would say the depersonalization, in my experience, is probably the most sensitive marker. In medicine, we tend to talk about sensitivity and specificity. The most sensitive marker I have found is that depersonalization. If you start to feel like you really don't care if the patient lives or dies or does well or not, you just can't anymore. You've got compassion fatigue. That's probably the marker that you're burnt out and not just regular tired. Now, this is a slide from a talk I actually gave a while ago. If you look, it's quoting a paper that came out in 2015. And a lot of the literature has been done on physicians. There's a lot of literature in nurses as well. But at that time, so this is some years ago now, burnout was already a problem for more than half the physicians in the United States. And if you look, you'll see that that was an increase from the previous study that was done by this group. Tate Shanafelt is an internal medicine physician who's done a lot of the research on burnout. He's now at Stanford. He was at the Mayo Clinic at the time this was published, where he did a lot of his work. When he did the study in 2011, it was only 45%. When he did the study in 2015, it was now up to 55% or 54%. So, it is increasing, and it's actually increasing almost exponentially if you look at most of the data. Now, some of it is we didn't have the words, right? We didn't have verbiage around burnout until the last few decades. And so it may be just we're diagnosing it more, and it always existed. But most of us do think there actually is a real issue. We do think that it is a real phenomenon, that people are getting more burnt out in healthcare than they ever used to. And so that was the situation before COVID hit. And as we all know, last year, kind of our world turned topsy-turvy, and we had to deal with the pandemic on top of all the usual stressors that were causing burnout in the first place. They didn't go anywhere. Because we had a pandemic did not make our healthcare system suddenly work better. And so we still had the same burden. So almost half the people were already burnt out. And the pandemic, as I think everybody knows, made it worse. It really exacerbated our already high rates of burnout. There is good data now that there was an increase in suicides among healthcare workers, depression and resignations, actually more than anything else, which is probably better than a suicide for sure. So, but there were a lot of people who were very frustrated. And I think what happened, and there's obviously, you could do a whole hour talk on just this, but on top of our regular burnout, I think people started to feel devalued. They felt like they weren't supported. They felt disenchanted. They felt helpless. They couldn't really make these patients better. And I think that just tipped a lot of people over. If you search for the Google search, the terms COVID and burnout, you get 121 million hits. So that just shows you how well talked about this is. So I'm obviously not going to discuss all the literature on COVID and burnout, but I wanted to share this article. It's by the Harvard Business Review, which is actually, you have to pay for that resource. However, they will let you have up to 3 articles a month free. I would recommend that you look at this, because I thought this was a very good paper. And so it's by Scott Burnout, and this came out in March, as you can see right at the beginning. But I've found this to be one of the best descriptors of this phenomenon, because he uses a framework that healthcare professionals especially are already quite comfortable with. And that is the grief framework. And he basically phrased it as, this was not for healthcare workers, by the way, this was just for anyone suffering with the pandemic. But he said the discomfort you're feeling is grief. That's what it is. And when I saw this, I was like, a bit of a light bulb moment, going, oh, that's right. It actually does feel a lot like grief. And, there's different kinds of grief. There's grief because our world is different. We've lost our normalcy. There's the direct grief by losing patients to COVID, losing loved ones to COVID, losing our colleagues to COVID. And then, and I think this was true for a lot of us, there was anticipatory grief, the uncertainty, the fear, that feeling of lack of safety. So there were these different types of grief, all sort of, interacting with each other. And a lot of us, I think, you can probably think of a few people who did go through the standard Kubler-Ross grief cycle, where you start from denial. We all saw that, right? Remember back in February of 2020, when this was all going to be over in 6 weeks, right? There was denial. Then there was anger. I think everybody saw anger. There was anger at being told you had to wear a mask. There was anger at not being able to go to bars and restaurants. That was definitely the anger part. There was the bargaining. And I think for healthcare workers, there was a lot of bargaining. Okay, if we do everything right, things will get better soon, right? And then they didn't. And so the bargaining wasn't working out too well. And then most people got to some part of depression. I really don't think anyone skipped this. There was some amount of just, I can't fix this. It's not getting better. 6 months, 9 months, we're still here. And then finally we get to acceptance and kind of moving on. And right now, most of us are in that phase because things have got a little bit better, but I think there's still that anticipatory grief. Is it going to come back? Will these new strains now make things worse? So, I think this model is still a very good one to use to try to make sense a little bit of how the pandemic in particular has affected us. Now, when we talk about cures for burnout, as Dr. Santos alluded to, I got into this world with my mindfulness training. And I'll tell you, I almost never talk about that anymore, because over the decade and a bit that I've been working in this field, we have now realized that 90% of burnout is systemic structural problems, and 10% is personal. And this explains a little bit why our forefathers, and they were almost all fathers, who were physicians and surgeons back when 1950s and 1960s, worked probably harder than most physicians today. They were up most nights. There's only every other day call or every night call. There was no work hour limits. They were tired, but they weren't burnt out. And we think the reason is that they were working in a system where they didn't have paperwork and they didn't have bureaucracy, and basically no one told them what to do. And so there was a lot of autonomy and not much structural pressure in any way. And that's completely changed, as everybody in healthcare knows now. And we think that's why this 90% is really systemic. So I'm actually going to talk about it in that context. So I'm going to start with the 10% actually, and we're going to talk about personal things, individual things that people can do. And then we're going to talk some about the 90%, because that is, while it may not be under your individual control, that's probably where the bang for the buck is in making improvements. So starting with the 10%, what can we do? It's really important, even though it's only 10%, that we optimize our 10%, because guess what? This is the only thing that's within our control entirely, right? I can't control you, and I definitely can't control the healthcare system, but I can control me and how I show up every day. And so if there's something I can do to make that 10% better, it's probably worth doing. And this is the context in which I'd like you to take this set of advice and ideas, because this is what you have the most control over. So here are some things that have been shown, and this came from David Keller. David Keller actually worked with Kubler-Ross and wrote actually a follow-up book to the original 5 stages of grief. So this actually comes from that same article, and then some other work he's done. Try to find balance in thinking. And this sounds a little kind of vague and flaky, but what it really means is don't get overwhelmed. Don't spend your entire day on the internet, on social media, reading about COVID or about whatever other crisis is there, because all of these mainstream media, social media, it's designed to amplify stress and, oh my God, look what happened today. And something bad always happens every day. So try to find some balance, set some time for that aside, but then set some time where you're not talking about the latest crisis, whatever that is. Come into the present. This is a big one for mindfulness. And so if we do eventually do a talk on mindfulness, we'll definitely focus on that. But it's to not catastrophize about the future. That's usually what happens, and not live in the past, but to try to be here now. And if you're here with a patient at work, or if you're here with your colleagues having lunch, then just be there and not worry too much about what else is going on. Letting go of what you can't control. That's probably a big one. A lot of healthcare types are very control oriented, right? We're a little bit control freaky. That's sort of usually an asset, but letting go of what we really cannot control and stocking up on compassion. Now you'll realize these are not very concrete things. These are ideas, but I think they're useful ideas, because you may have a different way of learning how to come into the present than I do. I do a lot of it with breathing in my abdomen and sort of centering in the body. Someone else may have a different way of doing it. But these are concepts that I think can help frame that 10% of what we can control, what we can make better. I want to share this. You can see what an important topic it is. This came out in General Surgery News, which is kind of a tabloid type publication and is really very widely read. And back in April, you can see that they talked about, this came from a social worker actually, tips for managing burnout. And this is some of what was in that article, focusing on our breath. And I think there's many ways to do this. If you already have a practice, perhaps a mindfulness meditation practice, then go to that. If you've never done this before, there's a standard method that's taught actually in the military as well. That's called the 4-second system. So I'm going to spend just a few seconds, maybe 4 seconds doing this, where you basically train yourself to inhale on a count of 4. So 1, 2, 3, 4, inhale, hold for a count of 4, exhale on a count of 4, and hold. So let's try that. It's actually harder to do than it sounds. So, I'm going to just kind of let you all try to practice that. And I can't talk while I do this for obvious reasons. So let's just try. Okay. All right. It actually makes me a bit short of breath. It's actually a little hard to do, right? Ariel's laughing. It is actually not that easy. But you know what? I guarantee you, every one of you that tried that was not worrying about COVID or anything else in those, 16 seconds? I will guarantee you, you were not. So this is a great technique, and they actually teach it before you're giving a talk, before an exam. It's great to really bring you into the present because it forces it. You have no option but to focus on that count to 4 and breathe. So if you learn nothing else from this talk, I would love you to learn that little technique. And if you just do it 2 or 3 times, you will find it really does calm you down and make some of the fluff go away. Take a break from the news. I already talked about that. We have to. It's kind of funny, I'm on Twitter a lot, as Dr. Santos mentioned. I do control that some, sometimes I'm on it more, other times I take a break. Some people make a big drama about, I'm going off for a while, I can't take it anymore. It's not an airport. You don't have to announce your departure or arrival. Just if you want a break, turn it off. No one's paying you to do this, guys. So, modulate. When it's fun, use it. When it starts to get stressful, stop. That's all. But you need to be a bit self-aware. You can get stressed from this and not even realize it. You can start to feel like if you're compulsively checking it, you need to stop. So use it if it's fun. And that's really what I do. I mean, and I don't make a big thing about it. I don't try to use it every day. I end up usually checking it some days. I just check it and do nothing. Other days I tweet a lot, usually when I'm bored. So if it's fun, use it. And if it's not, don't. But don't feel like this is something you need to be glued to. And at least for some time of the day, you've got to step away. And then go outside. Some people are great at this, others not so much. Really just being out in fresh air, especially as the weather gets warmer, is so therapeutic. For some people, this is really their main thing. Now, Lubbock does not have great forests and woods for us to walk through, unfortunately, but there's always something that one can do. And even if you're just walking around the campus here, it can be really nice when the weather's good, like today and yesterday. Take a break for lunch and walk outside. I haven't quite got into it. People talk in the corporate world about walking meetings. So instead of meeting in your office and sitting down, you walk. I can't do that. I really can't focus quite well. But if it works for you, it's something to think about. And then maintain social connections. This is a great time. Actually, the pandemic has given a lot of people actually a little more free time. There's less traveling going on, definitely fewer social events going on. Call people you've fallen out of touch with, call your old friends from school, call your family members that you have lost touch with. Try to build a network. You know, there's again a whole talk in social connections, but you need at least 2 or 3 tight connections is what most people think to be as healthy as possible from that aspect. 2 or 3 very close connections, maybe your spouse, your siblings, your parents, your children, you know, a few close connections. And then having sort of that second tier of friendly connections that maybe you're not as close with, but you're still having regular interactions. That's probably the place to work on. Turn some of your acquaintances into closer friends and maybe touch base with some of your peripheral acquaintances and make them closer acquaintances. It has been shown that even those casual acquaintances can help your health. If you have a positive interaction, that can help counteract some of the negative in the day. So now, I think the pandemic's been a great time to shore up those social resources. They are important. We know that people who are socially isolated die sooner. I mean, that's how important it is. And then professional support. Sometimes we actually do need professional help for this. What I've been talking about so far is really the do-it-yourself method for people who are a little burnt out, like all of us are at some point. They're not suicidal at all. They're not really depressed. They're not, you know, they're good most days. And then, you know, one day a week, maybe they just feel like the pits. By Friday, they're tired. But if you're more than that, if you're feeling a lot of moral injury and distress, if you've had a recent bad outcome, this has been shown for surgeons especially to have an impact. Recent moral injury, just a really bad case, someone that really got to you. Maybe it was a patient who was similar to you in age, sex, race, something that made you bond and you lost that patient. Maybe you were baseline burnt out and now you're starting to feel like you're losing that little bit of control you had. Please seek professional help. We have it here. I have encouraged in the last year at least 4 faculty, and I know our program for residency has encouraged several residents to use this. It is free to us. It's an incredibly generous resource. I'm very grateful to the School of Medicine and the Health Sciences Center for doing this. So you can contact them directly. Here's the website, or you can ask your supervisor to help facilitate it. But I really cannot emphasize enough how much I recommend this if you're feeling like you're even starting to tip over that edge. You know, just to listen. For some people, it's just organizing your life a bit better. Sometimes it's just someone who needs to hear you vent, but use this resource. You have up to 6 sessions free, and then more if you need it can be organized. Because really, we're not in this alone, and there's no reason to be. Okay, so I'm going to take a pause there. I don't think I see any questions on that segment in the chat room yet. Is that correct? Okay. So if there's no questions, then I'm going to go on to the 90% part of it, which is the systematic part. So this is the part that maybe as individuals we don't have quite as much control over, but as a team and as an institution, we definitely do. And it's something we can work on together. So I'm going to share a little bit about what we've done here in the Department of Surgery, some of the things I've done, some of the things the School of Medicine's done, some of the things the HSC has done. So when I use the term we here, it is very much the global we. It's all those categories of things, because really we need to work together at every level to try to make burnout just a little bit less prevalent. So before I start on that, why do I say the 90%? And is there any evidence to that? So it's fairly well established, but this study, you know, I didn't want to spend all this hour talking a lot about the literature. There's a lot of literature there, but rather than make it too dry, I was hoping to talk about active things that we can all do and then leave some time for questions for you all. So for that reason, you know, I apologize if we were expecting a lot of factoids and data, but this one I wanted to choose. And so one reason, it's a meta-analysis. So it includes a lot of studies on burnout. And it did something that I really like. This was done by Maria Panigotti, again, published in 2016. It's been around for a while. And it looked at a lot of studies and whether they measured organizational impact or individual impact. So some of the things for individual physicians, this was all based on physicians, was mindfulness, yoga, you know, the usual wellness package. The organizational ones were where there was more structural component of it. And if you look, I don't know if you'll be, yeah, you can see my arrow. So this is the 0 line means no difference, right? So I'm going to show you the 0 line on each side. Now have a look at the 0 line, and then where you want is to move into the negative side, right? That's less burnout. That's how this was structured. So the minus numbers are the good ones. So have a look. You can see that when they looked at all of these, and they'd have these standard deviation bars, so the individual ones worked, right? So the basic median line is to the minus. So it's on the good side of 0. So everything helped. but the space is more on the organization side. This went all the way to minus 0.5. This one was about maybe 0.2. So there was a significantly more beneficial impact of organization interventions versus physician. Here's another thing to look at. Let's look back at the physician side and the organization side. Let's look at the positive side. So it's unlikely that any of these actually increased burnout, but there's at least a few that you have to wonder, right? Look at this, these 4 interventions, these 5 interventions on the individual side, they actually might have increased burnout a little, or at the very best, they made no difference. And I'm going to assume it really was no difference. So 5 interventions on the individual side made no difference. And look at these 2. These 2 are like right at the 0 line. They really didn't make a difference. Now look at the organizational line. Every single median is on the good side. And the worst we get is, okay, this has a wide confidence interval. This one probably didn't make much difference, but it's still on the right side of the line. So when you really look at this, to me, the data is clear. Organizational interventions outperform individual pretty much every time. That's where we need, that's why I say it's the 90%. It's where we need to put our energy. Now, the best approach is a combination, right? And that's what we need to strive for. It's sadly rare because it's a lot of work. You need some resources to do this, but where we really should go as an institution, in my opinion, is these combination. We want to foster some individual approach, but we do want to put the majority of our efforts into structural. So what do we do? So here are some ideas. So this is kind of the ideas group. I've spoken to lots of people across the country, how they're doing it. A lot of it is adjustments in how we do our work. It's not what we do, it's how we do it. And that's best adjusted with input from the people doing the work. I think we sometimes get away from that. We assume that we know what's going to make a nursing student's life less stressful or a physical therapist's life stressful. But honestly, we probably don't. We need to ask those people. And so the best adjustments are those which we actually solicit input from the people we're trying to help. One of the concepts that came up, and this came from Wake Forest, big system now merging with Athena Healthcare, it's a huge system now. And they said that it was finding ways to reduce friction. So they created a program called 100 Small Things, and they asked the staff to find small ways to reduce the friction in daily lives. And I love that analogy because if you think about it, right? Like everything that makes us upset or angry is friction, right? You want to do something, someone wants to do something else. Now you're rubbing against each other, not literally, metaphorically, and getting irritated. And that's the friction. So how do we reduce that friction? And we just ask people, and you try to come up with 100 small ways to reduce friction. So that's an idea we may want to adopt, because I think sometimes those little things have disproportionate impact. They had a program called GROSS, and I won't go into it in a long time, but it was basically built on those reduction of friction concept. And then they looked at the big culprits. We know the electronic health record, everybody hates that. How do you make that better? I mean, again, that's a talk in itself, but it's true. I mean, the more pop-ups and notifications, you know, nurses, and I'm not that old, but I remember nurses used to spend a lot more time at the bedside, and now they're basically clicking at a computer all day. It's terrible. And so really at some point we have to go, enough is enough. Maybe less documentation and more actual doing of healthcare is the biggest thing we need to do. Parking. Paying for parking where you work is, to me, just wrong. Why should we? We're very fortunate here. We don't pay much, but still, you know, those are minor things that can make people feel cared for and, you know, valued at work. And so that's actually come up in multiple systems that, you know, paying for parking and not making people pay for parking was an improvement that seems to help. Ditto with having food either subsidized or provided. Childcare, huge issue for so many people, and having childcare availability, whether that's subsidized or even if you're paying for it, if it's on site, is huge. So these are some practical things, and we really need to look into that because, you know, whether you're a for-profit or a non-for-profit institution, you know, we need to plow some of our resources back into people in these practical, tangible ways, rather than investing in perhaps some really fancy things that people don't value maybe as much. It takes time, it takes effort, it takes resources. But these are things being looked at across the country in various systems. I don't know that I've heard of a system that has it all right yet, but these are some of the ways people are looking at it. They're also looking very strongly at peer support for burnout. This is being looked at in multiple ways. Peer-to-peer counseling was a big idea. It came out of actually Harvard. I think Mass General did something a while ago where you kind of trained people as peer mentors and that they were available to their peers. And it sounded wonderful. And a lot of places used it. And here's the kicker. no one actually accesses that system. Over and over, people have found they do all this, they train the trainers and they do all this work, and then no one actually calls. No one picks up the phone and calls this resource. It's very interesting to me, but this has now come full circle to where great idea doesn't seem to work. Here's what does seem to work, which is kind of weird. And it came through the pandemic, and it was Zoom rooms. It actually is nicer in person, but even by Zoom, it seems to help. And it's basically a room where people get to meet without any special training, but there is a facilitator who has some training, and they're not a psychiatrist, they're not a clinician often. There may be someone with some experience in leadership training, facilitation, or a counselor of some sort. So someone with a fairly rudimentary training in facilitating discussion. That's really where we're pitching it. We're not having specialized mental health services here. And just to facilitate people talking about, oh my God, I have 3 children at home and they're driving me nuts, and I can't work and I can't do anything. That's the level that seems to have actually people work and access. So it's interesting that groups that have tried this seem to have had better uptake than that peer-to-peer counseling. And I think the difference is it's focusing on what I've been calling sort of everyday burnout, right? It's focusing on what we all deal with. It's not counseling. It's not a mental health issue. It's just colleagues supporting colleagues through common problems. And I'm happy to announce through Texas Medical Association, through mainly the Lubbock County Medical Society, we have started a program that's very similar to what I've just described. And I'm very excited because we're hoping to reach physicians and just have a group for people to talk about. And so if anyone is interested, who's a physician, please let me know. Dr. Sandra Dickerson is the president of Lubbock County Medical Society. Ashley Sturgeon from our own institution was one of the proponents of this. So contact any of us and we can get you hooked up through the Lubbock County Medical Society because that's available. And I would love to see that similar program starting in our other health professions as well. I think it's an easy idea. It doesn't take a lot of time, doesn't take special expertise. You just need a few facilitators. And I think that's something that would be smart to adopt. I want to talk about some practical ways, we've been trying to walk the walk here in surgery. One of the things we did about 3 years ago was take away 24-hour in-house call for trauma and emergency general surgery because we are so busy on those aspects that really was a full-time job. You couldn't layer it on as call. Yesterday was unusual. I was the backup call person that got called in, but that's fairly rare for us. And by basically shifting people to 12-hour shifts, they do 15 a month, we have noticed a significant decrease on those people who did it both ways, the pre-24-hour call on top of a day job, and now the 12-hour shifts. We definitely notice a decrease in burnout. And I know that people prefer it because when we had COVID and we started looking after COVID patients as well, and we set up a separate COVID ICU, I asked the team, hey, listen, we've got to cover this other thing now. We just have to do our part. Shall we go back to the 24-hour call temporarily? And not a single person wanted to. And we found a way to do the job without actually going back there. So that tells me how much people appreciate it, is they did not want to, even on a short-term basis, go back. And that's kind of, to me, a walking the walk example of we did something that clearly has helped. Interestingly, I'm just going to put this out here because I am very proud of this thing. It's got national recognition. They're actually doing a 3-year follow-up in General Surgery News that should be getting published in the next few months. We reported this at American College of Surgeons. I believe Dr. Santos was involved with this one as well. And we showed that not only do we have happier surgeons, we actually had better patient outcomes and lower cost for our patients by going to this model. And lower cost means you can afford to pay for more surgeons because you do need more surgeons on this. And it's really part of not saying that physicians should be an unlimited resource. We shouldn't just keep working harder because we can. We should be working a decent job like everyone else with appropriate time off. And really, it's amazing to me, but that's a paradigm shift. For the longest time, we've kind of had a Navy SEAL mentality. We can do it. We're tough. We're Marines. We're really tough. We'll just keep doing it. And it's interesting. All of the backlash, almost all, actually, no, all of it, against this model when I started 4 years ago and to this day, every bit of backlash has come from surgeons. I have never had an administrator push back. They might whine a little bit about how much it costs, but they don't actually question the premise. They do not question the premise that this is the right way to do it. It's all surgeons, and it's surgeons going, well, we can do this, and we did it back in my day. And it's, it's kind of interesting to me that the people it was designed really to help are the ones who really would rather go back to just being beaten up all the time because we've just got so cultured into thinking that's okay. Work safety. This is actually a new aspect that I and others are focusing on because I've noticed, we've always had a concern about safety at work in hospitals and clinics for healthcare workers, physicians particularly. When patients just get mad, they tend to take it out on the front office staff, which is bad. But when they actually want to harm someone, kill someone, it tends to be the physician they focus on, usually sometimes nurses, usually the physicians. And those incidents have seemed to have gone up a little bit. Maybe they're getting reported more, I don't know. There have been some, and so we're looking at it. So I spoke to Dennis Lamb, who's a School of Medicine patient satisfaction person, Brett Majors, who's CEO of our practice plan. And we're actually talking about this, and we want to help these ideas expand to the greater school, because part of wellness is feeling safe at work. We want our people to not only be safe, but to feel safe. And so we're looking at, are we doing everything we can to be safe? We don't want this to be like a prison. We don't want, multiple checkpoints and barbed wire everywhere. But we want to know that we have taken reasonable precautions, that people can feel safe at work. Because honestly, in my view, it doesn't pay to talk about burnout. If people feel fundamentally unsafe, then that's where you have to start. It's also to do with psychological safety. Abuse should not be tolerated. And all of us have bad days. All of us get grouchy sometimes. You can give people grace, but a full-on tantrum, yelling and screaming at each other, that's just not okay. And we need to create spaces where that is just not the norm. And then I firmly believe, and always have my entire career, that there needs to be zero tolerance for racial or sexual harassment. And when I say zero tolerance, it doesn't mean that someone tells a slightly off-color joke and gets fired. That's not what I mean. But I mean acts of actual sexual harassment, or use of racial epithets, deliberate harassment. That cannot be tolerated. If it's a patient, that patient needs to, and it's not emergent, the patient needs to be politely asked to leave or to stop that behavior. If it's a colleague, it needs to be investigated through the proper authorities, reported to the EEOC. And I think that is important, because until we have a culture where everyone knows that there's a zero tolerance for some of those things, it's hard for people in those minorities to feel safer. A lot of people who are not in minorities don't actually see this happen, but those who are very sensitive to it. And I think it's our duty as an institution to really take those seriously and ensure everyone feels valued. So these are things we've definitely done within our department. We actually have a policy on it. And I know these are definitely congruent with institutional values. And I think these are just areas we can use to support our efforts in reducing burnout. Working from home, well, everyone's got a lot more used to working from home now because of COVID, and I think there's some good that came from that. Before COVID, we actually had in the Department of Surgery, the billing and coding staff work from home, and some of the administrative staff. And so for us, it was actually an easier flip than most. What we've decided is, even when those restrictions are no longer necessary, to have some flexibility, because it is nice sometimes to be able to just work in your pajamas for a while with your coffee there at home, and a little more flexibility. People get to take that sort of mental health day while still working at home. I think that's something we've learned from COVID. So not everything from the pandemic has been bad. I think we've all learned that we can be a lot more flexible. You can work at places besides your office. And honestly, I did not realize how well that could work. Truthfully, it's been good to see how that happens. We do scholarships for both staff, residents, and our students to try to encourage development and career growth. I think that's a way to let people know that they're supported. I think this is also important because one of the antidotes to burnout is finding meaning in your work. And sometimes your day-to-day work gets a little dull. Let's face it, if you have a job that's a little bit routine, I'm very fortunate, mine is never routine, but if you do have a job that can get a bit routine, learning something new, learning a new skill set and being supported to do that can really be valuable. And I'll give you an example. The first scholarship we awarded in our department went to an LVN who was going back to school to get her nursing degree. She was a medical assistant at our clinics. She did her degree and actually came back to us, and now she's one of our nurses. And so I think that it's also a retention tool, because people appreciate that you're investing in them and their development. We try to have celebratory events. We don't get to have parties now. So now we just kind of take donuts to people, individually wrapped, of course, and things like that. I think we need to celebrate. We need to celebrate surviving pandemics. We need to celebrate that we're all here and healthy. So, I do think that in times of stress, spending a little extra effort on the positive is fully worth it. I have a firm policy in the department. Everyone knows you're not allowed to schedule a meeting between noon and 1 o'clock without lunch. So I'm going to have to forgive you all. But since I can't eat anyway while I'm talking, I'll forgive you. But the department policy is that you're not allowed to actually schedule a meeting that crosses noon to 1 without lunch. Food is my love language. And so if we have a noon meeting in the department, we provide food because we don't want people to starve. Like I said, I'll give you guys a pass this time. We have a wellness program. There's also an institutional wellness program, and I think that's great. I think it's something to focus on. We talk about physical safety, and I wanted to come back to our values-based culture, because what I love about the fact that we already have this values-based culture is that we can use that to integrate a lot of these burnout efforts within one or the other. The symbols are there. I'm sure you all know them. We've all been definitely told a lot about them in the last year and a half. So, you know, one or the other of these values, especially the kind-heartedness and the one team, can really speak to a lot of what I've already said. And so in conclusion, I think that the pandemic has definitely made things worse. It's given us a few new solutions, but on the whole, I'd say it's probably made things worse. There are no good solutions, but there are reasonable solutions. And I think multiple reasonable solutions can help at least move the needle in the right direction. I think we need to take a dual approach. I think we need to tackle crises on one hand, people who are really struggling. I think that's where the formal counseling referral to employee assistance program comes in. And then we also need to just rebuild a better system for all of us so that the act of providing healthcare is not so stressful on the people who provide it. Okay, so with that, let me stop my sharing, stop sharing. Okay.
Thank you very much, Dr. Dissanayake, for that wonderful talk. It is nothing short of informative and interesting. And sorry about the noon conference, but we will be back on the 25th for, in 1 to 2 again, usual time.
I'll forgive you because this is online. So actually everyone listening can have their lunch at their desk and just, black out their screen. So you're forgiven on this one. It's the in-person ones. I just don't understand. People will have in-person meetings at a table and make people starve over the lunch hour. I don't get that. I really don't. So this one's okay because it's being broadcasted to people's rooms, and if they want to, they can eat.
And again, this is not what, this is not just, being preachy or whatnot. We're really doing this. And I'm actually glad when I started with the program, we're doing a 12-hour shift because I cannot go back again to the 24-hour shift. And this is one of the systemic things that you have been changed. So thank you very much for giving the talk and for walking the walk, walking the talk. And we have Dr. Vaughn who would like to, make a comment or ask a question. Dr. Vaughn?
Wait to put your junior faculty on the spot.
No. So we, I don't have a specific question, but I did want to kind of echo his thoughts on, I think it's a real topic. And then, especially thinking back on my recent training, I feel like we have the potential to watch out for burnout in our colleagues and identify those things and address them on an individual, personal level to kind of catch things early before they get too severe. So it's a topic near and dear to me. I think we're all prone to it. And even as, managing your ICU, watching out for it in your staffs and the different ranks. So especially with the COVID amplifying everybody's intensity and risk for burnout, I think this is a very timely and relevant topic. But I didn't have any specific questions. I just think it's good that it's something to revisit and talk about.
Thank you, Justin. I think, you make a good point about watching out for each other. I didn't really talk much about that, but I think that, so when I teach trainees about medicine, I always say err on the side of caution. And what that means is if a patient has a slightly low blood pressure and one reason might be they're bleeding or the other reason might be they got too much morphine, assume the bleeding reason, right? Err on the side of caution, deal with the dangerous side first, and then you can, if it's nothing, it's no big deal. Same thing, I think we need to err on the side of caution with our colleagues. We need to assume people are struggling a little bit. And I think reaching out more rather than less is the side right now. Anyone who has any leadership role, whether it's formal or informal, like you said, Justin, when you're in the ICU, you're the leader of your team, right? And whether you're a fourth-year med student with a third-year med student or a second year, it doesn't matter. You don't need to have a formal role. But I think reaching out to your own peers and frankly, even reaching out to your superiors and seeing how they're doing is valuable. Nobody minds hearing that someone cares about how they're doing. I mean, no one's ever going to get mad at that. But I think reaching out and just going, hey, how's it going? Did you have a good weekend? Just trying to just reach out and see how people are doing. Or, hey, I noticed you've been looking a little down. Is everything okay? It's not going to hurt. And I think we need to err on the side of caution and assume people are struggling a little bit more than they might otherwise. Laura asked a question, does medical training and education integrate wellness into the curriculum? So the answer, Laura, is yes. And here's the problem I have with it. I always have problems with how things are done. The problem is it's become a checkbox, and this is how things naturally disintegrate, right? So yes, we must make sure trainees are not sleep deprived. So what's the solution? They must be forced to listen to a mandatory talk on sleep fatigue management. Check, problem solved. You know, that's just how the world works. It's defaulting to the easiest, stupidest way to do things, and it is what it is. So yes, I will tell you, there is not going to be a medical training program in this country right now that does not have wellness in the curriculum. How much that actually correlates with the wellness of the students and the people involved, I would say probably very poorly. I will guarantee you that places that have med student suicides have a wellness component in that curriculum. I would be shocked if they didn't, because it's just devolved into a checkbox. And so the answer is yes, but are we walking the walk? Probably not as well as we could. And so I would just encourage everyone on who's clearly, if you're on here, you're interested in the topic, that it needs to be, any efforts we make should have a tangible effect on someone's wellness. Let's not do things to say we're doing things and to check that box. And I think, you know, that's just how we need to orient ourselves. I'll tell you that, you know, obviously we've been working on this for a while. I can see Dr. Richmond on the call. She's our wellness coordinator for the residents. Some things work, some things not so much, right? And we have done things that I have stopped doing because people didn't seem to care that much. And there are other things, like we just talked about, the shift to 12-hour shifts, nobody wants to let go of. So you can clearly tell people will vote with their feet for what works. And so we need to do just good scientific method. Try something out, get some feedback, evaluate it. And then if it's working, continue it. And if it's not working, get rid of it. And that needs to be the approach we take to wellness, not here's your yoga session and be done with it. Yoga's great, by the way, I don't mean to slam it, but it just is such an easy fix and such an easy way to check that box that I think it defaults to kind of almost being a joke. You know, there's a joke that here's a mandatory wellness curriculum that people are going to make us attend at 5 p.m. You know, it happens. It's just ludicrous, but you know, a lot of that happens across the country. We have a question from Rohan. It says, in regards to the systematic approach, how would you suggest we go about implementing changes? Well, it helps to be the chair. That makes it a lot easier to implement. But, so first work on that. And once you become chair, you can do all these things. But no, I would say that you need to, when you do have a forum, right? Everyone has a forum somewhere. So you have a meeting, whatever you are. And Rohan, what are you exactly?
I'm a junior biochemistry major in Texas Tech at the moment.
Okay, great. Welcome. Thank you for being here. So I would say that at some point you are going to have an opportunity to give feedback to those who are working with you. If you start to go into a healthcare profession, whatever that profession is, you will have an opportunity to make an impact. And I would say speaking up, going, hey, I had this idea, you know, send an email to your supervisor. So I'll tell you what I talked about, the physical safety. Realize I have no authority over the physical safety of this institution, but I can definitely send a few emails going, hey, listen, this is becoming an issue. I think that rather than wait for someone to go shoot a few people up, why don't we start thinking about safety now and get the attention of the right people? And then you get the right people in the room and something happens. Anyone can do that. And while yes, having a title helps, you can get, if you don't have a title, it helps to get a few people together and go, hey, a bunch of us think this. And then even if you don't have a formal title, people will usually pay attention. So those would be the two ways I would recommend, that until you have any sort of formal authority on it, if you have a good idea, make a few other people agree with you that it's a good idea. And then as a group, try to take that up to someone who might have authority to fix it.
Ron is very interested in going to a medical school, and I've been mentoring him. And we have also Dr. Richmond here in our forum. Dr. Richmond, any comment or questions?
I just wanted to ask a question about your thoughts regarding our social connections. So, you know, that's so important for our personal well-being, for morales of groups. And you and I have spoken a little bit one-on-one about the struggles in the times of COVID with the restrictions that we have in place by the institution and by the, you know, local authorities for good reason. But how do we how do we bring those two together? I mean, how do we help encourage those social connections while still being responsible to, the health and well-being of our surrounding area?
It's a good question, and obviously, as you know, Robin, we don't have a good answer, but I think we do what we can. So so the running club we have in the department that you've been instrumental in starting, that's something that I think could probably continue. It's a small group. It's 6 of you any given time. You're outdoors. You're running. You know what? Sorry, or give me 2 seconds, guys. Hold on. Okay, sorry. So I would say we have to do what we can that's safe and reasonable. And then the rest we do have to try Zoom meetings that work. We have to, I think, try, I think you can go to extremes in anything. So I know there are people who haven't hugged their kids or their parents because they're so worried about COVID. To me, the downside of that probably honestly outweighs the very small risk of those one-on-one interactions. So I think that, small groups of people who have all been vaccinated choosing to say, the risk is not zero, but there's a risk to our mental health by being apart, and choosing to get together for a meal. What we do. So in my family, and I think I've told the department this before, in my family, what we do is we have, Michael's children over and his dad, and we sit, so we're lucky we have a big living room. We sit on the corners and we have little tray tables. So we all have dinner, but we're all about 10 feet away from each other once you triangulate it. And that's what we do. And it works just fine. You don't have to sit at a dining table, you just sit apart, and we wear our masks when we're up and around. And so you can do that. And I think a little flexibility. I think we can't be so rigid about the pandemic precautions that we are, driving ourselves nuts. That's kind of my approach. Now, the problem is, as an institution, we can't exactly be as flexible, right? So I think the answer is, it's hard as an institution to sanction a group event. It has to be done individually by individuals deciding, hey, this group of friends is on their own accord going to do something for their mental health. And I think just legally, we don't really have a choice in that. I mean, sometimes an institution sanction is different, but the institution isn't going to prevent individuals from doing their thing. And I think that sort of gray zone, much as I hate having to walk into the gray zone, I think the gray zone is what we have to capitalize on until we get something. Clearly, with the governors revoking the mandate and kind of opening up to 100%, there's a little bit of legal cover right now, but I doubt that the institution wants to still go back to no holds barred things. So we just have to kind of thread that needle and do what we can. And so what I would say, Robin, from an institutional perspective, I definitely am not going to police private gatherings that people in our department may want to have of their own volition, but I'm not going to sanction them either. And so that's the step I would take. And, it's suboptimal, but what can you do? I can probably take one more question, guys. It's 12:50 before I have to go to the OR.
Dr. Tompeck, do you have any question? Dr. Tompeck is from the University of Arizona, Banner. Do you have any questions or comment?
Yes, hi. Thank you so much for that wonderful talk. I was just sitting here thinking about how surgery is so team-based, and that team often, in terms of ICU, includes respiratory therapists and nurses and other therapists. And so as a team leader, which is often the surgeon's role, how do you recommend we integrate this so that it's a daily habit, say on rounds, but then also across these specialties, as I'm not their direct, maybe boss, but of course we are a team and I care about everybody's well-being and the effectiveness of the team.
So I think it goes back to practicalities, right? It's going back to making sure people feel supported. And this absolutely happened during the pandemic, the peak of it, it's making sure that everyone has masks, and we did that. We actually gave some N95s to respiratory therapists who didn't have access at that time. I mean, it's looking out for your people in practical ways. It's supporting them when there are difficult decisions and patients aren't doing well. It's taking the time to debrief. It's talking about, hey, this sucks. What can we do? And so I think it's situational. So the answer I think is, our leadership in that space is situational, right? It's predicated on being the ICU attending for that week or month or whatever it is. And so we deal with it in that situation. When something bad happens, a code or something, you do a debrief and you talk to people and how are people doing it. You know, we did have a case where it felt like a triage situation where there was one resource and who do you give it to? That's incredibly stressful for people. We recently had a case that really caused a lot of moral distress among multiple people involved. You talk to those people as the leader and kind of reassure them, you know, this isn't your fault, this happens. You see if they need time off. You can always talk to their supervisor if you feel like they need a little extra space and maybe a little less intense of a day or two till they recover. So I think there are ways, and I think that kind of leadership, as with most disaster leadership, is best led from the bottom up. So rather than have a global mandate of, okay, you need to do this, this, and this, I think letting it be situationally aware. I think probably as leaders, what I need to do more often than I do is we just tend to forget and to check in more on how people are doing. And I think I'm very glad you asked the question, because we can probably all just check in. I already said it, we should all check in on each other, but probably as a leader, we have just a little bit more obligation to check in on the whole team than the others do.
Thank
Well,
you.
Thank you very much, Dr. Tompek, and thank you very much, Dr. Desanaka. And we are presenting you a virtual coin, you know, as a token of gratitude for this talk. And this will be available as well as recording. And don't forget that on March 25, 1 to 2, not noon, we will have a burning topic, the burning bridge to nowhere, dying slowly in the ICU. Next slide, Jimmy. Next slide.
Okay. Let me share it here.
By the way, don't forget to use the QR code for the evaluation. Next slide. And this is our virtual coin, Dr. D. And this is the next topic for next week, Burning Bridge to Nowhere, headed by the palliative medicine team, Dr. Lux, Dr. Klein, and Dr. Murillo, and Dr. Abbott. And the Society of Critical Care Medicine will be collaborating as well. Thank you very much, Dr. Tompek, Dr. Richmond, Dr. Vaughn. And I would like to thank Laura and Jimmy for the assistance. Thank you very much for joining us. Have a good day.